Okay, David, you should be good to begin.
Okay, well, I would like to welcome everyone to part 2 of our webinar, this one entitled Team for the Global Response to COVID. We're going to delve into the partnerships that civil society organizations have formed with government, and hear from civil society, what are their lessons learned in terms of the COVID response in regards to the workforce in particular. And it's really a wonderful opportunity to bring together our partners. We're the Frontline Health Worker Coalition, but we encompass a broad range of partners. I want to thank all of them for coming together to organize this exciting panel that we have for you today. I want to thank our translators and all of you participants that we have online. Thank you so much for joining. Have a look on your screen there. You'll see the chat button. Click on that and then add in your name and let us know if you're a civil society member. Are you part of a government? Are you a health worker? Tell us about yourself. And then you also notice on your screen there, the Q&A function. That's where you can enter questions. So I'd like you to start thinking now, what are some of the questions that you would like to ask? Is the workforce ready for a coming pandemic, not just the current one? What do governments need to do? How could civil society partner more effectively? And what are some advocacy strategies with regard to the workforce and government? So be thinking about your questions on all of those topics. And our fantastic speakers are going to really stimulate your thinking on these issues. So in part 1, just to recap a little bit, and I would really welcome you to go to our recording of part 1, because it was really fascinating to hear from the governments. That was the focus of part 1. We heard from governments in 5 countries, from Kenya to really quite a range, Uganda, quite a range of countries, and heard about what are some of the creative solutions that governments came up with in terms of workforce policies, how to manage a crisis. COVID-19 presented challenges on a scale we haven't seen in many, many years. And so this is something that governments responded to, in many cases, quite effectively, but also with some challenges. And so we heard from them in terms of how did they manage the workforce challenges of that? How did they reallocate workforce? How did they plan effectively? Have a look at that recording, because it was quite interesting. Another thing that's happened since is President Biden convened a really important summit on the COVID-19 response. This took place last week on the sidelines of the UN General Assembly. And one of the topics that did come up was the need for PPE, was the need for special support for delivery of COVID vaccines, meaning last mile delivery and including the workforce necessary for that. But besides PPE, we really didn't get much from the government leaders on the workforce. From civil society at that summit, on the other hand, we heard a lot about the workforce. We had, for instance, Polly Dunford with InterHealth contributed a video, and you'll see that on the State Department YouTube channel. We can put up a link to that. There was also a fantastic presentation by a young nurse from Kenya who spoke to the entire group gathered for the summit, including Vice President Kamala Harris and others, about the challenges that workers have faced in Kenya and what moved them, in the case of Kenya, to actually go on strike, and what was the outcome from that. And so it was fascinating to hear from her and why she feels world leaders must come together to address the needs of the workforce, not just PPE, but beyond PPE. So that, I think, was a really important presentation. We can share the link in the chat function there too. We'll be posting that on our website. And I would like to also now share with you a video that the Frontline Health Worker Coalition has put together that really shows the urgency of this issue, not just for the current crisis, but even preparing for the next. So let's have a look at this video.
We were not prepared for the COVID-19 pandemic. We did not have enough masks, or the protective equipment. Health workers were overwhelmed, and there were not enough of us to treat the huge number of patients that were overflowing in the facility. We are still not prepared.
Every country must have a strong health system and a workforce that can detect and stop unexpected threats.
The global death toll for health workers has reached at least 115,000.
We have lost many health workers to the pandemic. We can't afford to lose anymore. Viruses do not respect borders. We must strengthen health system everywhere to prevent the next pandemic. Government leaders have made commitment to do this around the world. Now, we must hold them to their promises.
The world will lack 18 million health workers by the year 2030 without adequate investment.
With increasing health needs, these shortages have serious consequences.
In Uganda, 14,000 patients miss medical care when just one doctor dies.
Our patients need us, and if we are not safe, our patients are not safe.
Applauding health workers does not cure disease, provide life-saving treatments, or prevent women from dying in childbirth. People do. It's time we invest in them.
The community healthcare workers program and the frontline will be extremely important in the coming months and if not years in our ability to fight COVID.
We must act now to prevent the next pandemic.
Let's ensure health workers' safety and security, provide funding for surge capacity, and continue to train more, even in this trying time. Contact leaders in government today and tell them we can't wait for the next pandemic to support frontline health workers. We need to act now.
As you can see, it's a very powerful video, powerful message that really calls on government leaders to take action. And so I just recommend you to have a look at that video again. You'll notice it on our website, and you can circulate the link to the video to your government leaders, your policymakers, and help get that message across. Because really, it's we can do something in our own sphere, of course, as health workers and as NGO leaders, but let's get that message to the policymakers as well. So now I'm going to turn it over to Esther Nasike as our moderator. She's the Advocacy and Policy Manager at PATH Uganda. And with 14 years of experience, she brings a lot to this conversation. And I'm so glad we have the opportunity to work with PATH and with Esther on this. So Esther, I'm turning it over to you.
Thank you so much, David. Thank you for your thoughtful introduction. Hello, everyone, and greetings from a rather sunny city in Uganda called Jinja City, about 100 kilometers from our capital. Thank you so much for joining us today for part 2 of this conversation on health workforce policies for pandemic response and preparedness. Now, just to set the scene a bit, regarding health workforce policies for pandemic response and preparedness, it's been 18 months into the pandemic, and we imagine that health leaders have a clearer perspective of what works and what doesn't work in pandemic response and preparedness. And from where we work in our different countries, we have seen how governments and ministries of health and civil society have identified innovative health workforce policies and practices to respond to COVID-19, but also support the distribution of COVID-19 vaccinations, and yet also ensure that there is continuity in terms of essential health services. So you can rest assured that there are quite a number of experiences and lessons from around the globe, from Africa to Asia, on how a resilient and responsive global health workforce can improve health systems, can restore essential health services, but also improve pandemic preparedness. So we shall be hearing some of those experiences today. But before I introduce our panel, and it's a fantastic panel that you're going to listen to this afternoon or this morning. I don't know where you're joining us from. Let me just share a little bit about our experience in Uganda. Now, following the outbreak of COVID-19 in the country, it was obvious that our health facilities and workforce were overwhelmed by the plethora of activities related to controlling the pandemic. There was a risk that essential health services, which communities expect from the health system, would be compromised, but also the workforce would be affected if they were not adequately supported. So PATH, which is the institution I work with, in partnership with the Ministry of Health, WHO and UNICEF, but also other partners, supported the development of guidelines on a continuity of essential health services during the pandemic period. Now, this was important in not just ensuring that essential services continue, but also maintaining people's trust in the health system to deliver the health services. It was also important that this guidance is available to minimize an increase in mortality and morbidity as a result of the health conditions that were prevailing at that time, but also offering guidance to the health workforce in both public and private facilities, regarding working conditions, improving availability of health workers, which had been affected by the restrictions around movement, around transport and everything, but then also even issues around remuneration and incentives for health workers. But also as part of that guidance, we were looking at issues around infection control and prevention, not only at facility level, but also at personal level, and supporting the governance and coordination of the health workforce right from the national level to the subnational level. But as you know, having guidance is one thing, but it is also important to think about the implementation, making sure that the guidance reaches the last mile. And so as part, we did support dissemination, ensuring that the guidance that has been developed reaches the last mile, and we were able to reach over 3,000 frontline health workers with the guidance that had been developed. And as a result, the country has actually registered fewer deaths of health workers in the country. I think the current number starts at 37, but we know that it would have been worse if the guidance had not been provided. Now, as the context changes and as new information becomes available, we continue to work with the Ministry of Health to update the guidance and ensure that we disseminate to the frontline health workers so that it is helpful at that level. Now, this conversation today is not about me. Like I said, we do have panelists that are going to help us dive in. Now, allow me introduce to you our 4 panelists. And in no particular order, I must also mention that it is a very gender balanced panel. So if you want to apply the gender lens to that, it is taken care of. So I'll start by introducing Mahbub Alam, who leads the family planning service delivery team for Pathfinder International with the USAID Suki Jibon project, and is responsible for the project's technical coordination with the Ministry of Health and Family Welfare. He also has a distinguished career working with the Ministry of Health and Family Welfare in Bangladesh for more than 20 years. Alam, I hope we can all see you on video, so you're welcome. And our next panelist is Lilian Mwape. She's a nurse working with the South African Development Community Technical Expert Working Group as a focal point person for Zambia. She is also the chairperson for clinical practice for East Central and Southern Africa College of Nursing in Zambia. And with this, she is responsible for all nurses and midwifery programs. She is specialized in clinical nursing, operating theater nursing, and law. She is our second panelist. And I will also introduce Dr. Montenegro, who is a medical doctor, a sociologist, and the director of the Reproductive Health Observatory, which is an organization that was founded in 2008 by the Guatemalan Congress to identify and monitor cases of pregnant girls and adolescents to contribute to the reduction of maternal deaths, strengthen the work of midwives, but also support victims of sexual violence. Dr. Montenegro, you are welcome. And finally, let me introduce Tracy Kobchindo. She is a nurse, she's an advocate, and a technical coordinator at Last Mile Health, where she utilizes digital online tools for the training of health workers, including community health workers, in partnership with the Ministry of Health. And as a nurse, she has worked in public health facilities in Uganda, and that has that has helped her to set up 6 health facilities in rural, hard-to-reach areas in Uganda. Tracy was named as a 40 under 40 influential leaders by one of the leading newspapers in the country. You are welcome so much, Tracy. So those are the panelists that are going to help us dive into our conversation this morning or this afternoon, depending on where you are joining us from. So allow me to start with Alam from Bangladesh. I just would like you, Alam, to share with us how the COVID-19 pandemic has affected, community level family planning services delivery in Bangladesh. How has the pandemic affected that? Please share with us.
Thank you, Esther. Well, in Bangladesh, a family planning service delivery is provided from the facilities, backed up by strong service delivery network at the community level as well. So at the onset of the pandemic, we saw service delivery disruption both at the facility level and at the community level. So what we have seen at the community level, there are mainly 3 types of approaches followed for community level services. One is domiciliary level service delivery, another one is courtyard meetings, and the satellite clinics. So all 3 approaches or all 3 service delivery networks at the community level were on hold, particularly at the initial stage of the COVID pandemic. And what happened at the facility level, we have seen people are not coming to the facilities for their services because of fear and other factors. And we have also seen reduced working hour for service providers at the facilities. And the consequence, you can imagine, the consequence is drastic reduction of antenatal checkup services. Facility delivery also reduced to a great extent. And all types of family planning service uptake has been reduced sharply. And the reduction range is 20% to 64%. 20% for oral pill acceptors were reduced, and 64% of the long-acting methods users also reduced during that time. So given this situation, what we have seen in the national database, particularly at the first 3 months of the COVID pandemic, we saw a nosedive in terms of family planning, acceptance, and accessibility. Over.
Thank you so much, Alam. I want you to still share with us about how you were able to navigate some of those challenges. What solutions did you propose? How did you deal with the challenges that you are facing?
Well, as an organization here in Bangladesh, Pathfinder has been implementing USAID flagship family planning program. We call it Accelerating Universal Access to Family Planning. And under that program or that project, we support Ministry of Health and Family Welfare in implementing family planning service delivery. So at the initial stage, what we did, we provided infection prevention training to the family planning service providers. We have also provided some PPE supports to the frontline FP service providers. And the most important thing that we did, that we supported COVID task force at the national level. For that task force, we coordinated with UNFPA, Bangladesh UNFPA team, and we have taken representatives from different stakeholders, from university, ministry, UN organization, international organizations, and from civil society as well. So that we actually facilitated that task force. And that task force came up with a number of recommendations for the Ministry of Health to implement, to overcome those challenges. And those recommendations were in the areas of distribution of family planning methods at the community level at increased quantity, And they also came up with a recommendation to ensure task sharing at the community level and to ensure uninterrupted contraceptive supply at the community level. They recommended the ministry to introduce depot holder initiative, and the task force also recommended to increase method choice in the basket. Particularly, they recommended DMPSC to introduce at the community level. And the task force also suggested government to ensure triage and other COVID protocol while AP service providers are providing family planning services at the facilities level. So government, after getting that set of recommendation, government initiated some of the activities from that recommended activities, and we saw recovery of the family planning service delivery in terms of accessibility and practice.
Well, thank you so much. Thank you so much, Alan, for sharing that. Now, from Bangladesh, let me pivot to our first speaker from the African continent, and that is Lilian Mwampe. Now, Lilian, you do advise the regional body, that is the South African Development Community. How has SADC responded to the pandemic, and how has this SADC as a regional body worked with the government to improve health workforce policies in the different countries in the region? Share that with us. Lilian, over to you.
Thank you very much. So it's Southern Africa Development Community.
That was an interruption. Please go ahead, Lilian.
Thank you. So SADC stands for Southern Africa Development Community.
La Comunidad de Desarrollo de África del Sur.
It has member states from the southern region of
Tiene
Africa.
estados miembros del sur, de la región del sur.
So as SADC member states, we realized that surgery was the most affected in all services that were
Y
being
nosotros nos
provided.
dimos cuenta que éramos los más afectados en lo que se refería a los servicios.
So a team was formed to look at how we can best ensure that surgical services are provided despite being at the epic of the pandemic. So a technical working group comprising of surgeons and staff from anesthesia, the nursing teams, as well as other stakeholders to help support surgical services in the region. So as a team, we're meeting every 2 weeks.
Entonces nos estamos reuniendo cada 2 semanas
to share best practices to
para
ensure that
compartir esto y asegurarnos que los 2 países puedan ponerse al día y aprender de aquellos que ya están más avanzados.
One thing that was key is that surgical services have a huge backlog
es que
between 3 to 6 months. And with the coming of COVID, we are now beyond a year of backlogs of patients. This was a source of concern as we lost some patients on the waiting list, as well as we couldn't even track all the necessary interventions that were needed, as most of the workforce under anesthesia was pushed to offer services in the medical wards that required critical care services. As a region, we do not have enough intensivists to cater for the critical care patients. So all efforts from surgery was concentrated to help cope with the pandemic in all the medical wards that were turned into COVID wards. So this being the case, governments through the technical working groups who had representation from all the ministries of health were able to come up with guidelines in order to ensure that services were not disrupted unnecessarily. And those that could cope were able to apply best practices
Y
learned.
entonces ellos pudieron utilizar estas prácticas. Me parece, I think they're still hearing me with the speaker.
Yes, Gilka, hold one moment. I need to get you back into interpretation.
Okay, let's just take a minute and as the technical team sorts out some of the glitches that we're seeing now. Can I say it's sorted now? Can we continue?
One moment. Okay, you can continue. Sorry for the interruption.
Okay, thank you so much, all our attendees, for your patience. Lillian, please carry on.
So in terms of policies, Southern Africa was worst hit from the second wave to the third wave. That's when we saw the true pattern, because it affected the healthcare workers who were in the direct service delivery category. That's those, the clinicians themselves. And we saw that we were losing critical staff from anesthesia, from the doctors, and from the nurses. And you find that most of these nurses were highly skilled nurses who couldn't be replaced by a new nurse or a doctor or an anesthetist. The huge investments that was put into these health workers went down the drain as we had no capacity to cope with the demands to prioritize the health workers as demand was beyond acceptable limits. So I'll give an example of Zambia, where my hospital was designated as a hospital for health workers across the country. So most health workers who required critical care and intensive care were brought to this hospital so that we could prioritize and save as much as possible these essential health workers. Because keeping them in the general hospitals where this care was being like a scramble for services was quite difficult, because you had to decide between a colleague and the person you don't know. So in order to ensure universal coverage of clients, we had to designate a hospital just essential for health workers, and to ensure that we also motivate these health workers as before there were challenges of whether to accept to go to a COVID center. So with the coming up of a designated center, we saw a gleam of light where health workers were comfortable coming in, despite them knowing the consequences, despite seeing other colleagues dying, they were dignified in the healthcare they were getting, as well as we created incentives for all those working around the health workers to ensure that they are motivated, they do not get discouraged looking at how the fellow health workers were like trying to cope with the complications that were arising. As SADC, we gave this example, and most countries did the same. We saw, we learned from Zimbabwe, Zambia, we learned from South Africa, which had the highest burden. Through this sharing, we were able to create synergies that would help support. Despite having the meetings, we were able to relate outside meetings and learn and follow up on how others were doing their best practices and achieving the goals for COVID support.
Okay. Thank you so much. Thank you so much, Lydian. I like what you have raised around sharing best practices by the countries in the region. I think that is really important, especially given the fragile context that the COVID pandemic has presented in many countries. But I also want you to just share with us a bit about why you think it's important for governments to invest in nurses with specialized skills like, surgical care for responding to future pandemics or any other health crisis.
We cannot win this fight without proper nursing care. COVID has just brought a limelight of the weaknesses that we have in our systems. Traditional nursing won't take us anywhere. The era of Florence Nightingale is over. We have to recreate the Florence Nightingale with a new dawn, meaning that the basic nursing cannot cope with the emerging diseases that are coming up. Critical care is key for us to win this fight. Hence, governments have to prioritize critical care skills, critical care equipment, critical care environments that are enabling to ensure that whatever standards we set, it's a win-win situation. Investment should equal the skills. Without skills, it's still a loss to all government economies.
Wow, thank you so much. Thank you so much, Lydian. I love what you said about the era of Florence Nightingale being over. We need critical skills. We need new, nurses that have a new thinking, to support the current crisis that the world is facing. That is very powerful. Now, let me move to a panelist that is from Guatemala, and that is none other than Dr. Montenegro. And Doctor, I want to come to you and ask about your work with OSA and how you have worked with the Ministry of Health to ensure that there are policies in support of the health workforce, but also policies that support continuity of essential health services. Share with us your experience as civil society partnering with the Ministry of Health to ensure continuity of essential services in Guatemala. Over to you.
Buenos días, gracias por la invitación a participar, compartir y aprender. Nosotras como organización tenemos 12 años de trabajo en el campo de la salud materna y neonatal, con aprobación de leyes, normas, protocolos, siempre en beneficio de la salud materna. Sin embargo, con el tema del COVID hemos tenido que variar al tema de la desnutrición infantil, al tema de la violencia sexual, porque es parte de lo que estamos viendo como efectos de COVID, y a la equidad en la prestación del servicio. No cabe duda que el COVID reconfiguró la vida y la realidad de las personas, las familias, pero también reconfiguró los sistemas de salud, y le dio nuevas prioridades a los sistemas de salud y a los presupuestos de salud. En el caso de Guatemala, las mujeres embarazadas ya no tuvieron acceso a controles prenatales, a atención del parto, a todos estos servicios preventivos, como es la suplementación de sulfato ferroso y ácido fólico. Y lo que vimos es que se incrementó el parto domiciliar atendido por comadronas, es decir, en el domicilio de las mujeres, se incrementa también las complicaciones obstétricas y la morbilidad y mortalidad materna. Nosotras como organización de sociedad civil lo que hacemos es traemos datos, hacemos análisis y comparamos. De nuestra comparación de los indicadores de prestación del servicio 2019 y 2020, podemos ver, por ejemplo, cómo se disminuye el control prenatal en un 30%, cómo la planificación familiar se disminuye en un 50%, cómo el tema de la prevención del cáncer de cervix se disminuye en un 80%. Los promedios a veces no nos dejan ver que hay poblaciones que son más vulnerables y a las que más afecta el tema del no acceso a los servicios. Entonces, con estos datos y con los casos, porque nosotras levantamos casos en lo local para conocer cómo se da la realidad de las mujeres, de las adolescentes, iniciamos un proceso de incidencia con el Ministerio de Salud. llevando nuestro análisis de, mire, estos son los porcentajes que ha disminuido el acceso de las mujeres embarazadas o el control prenatal. Lo hicimos con el Ministerio de Salud, con uno de los viceministros, y lo hicimos también a nivel del Congreso de la República, con la Comisión de Salud. ¿Qué fue lo que obtuvimos? Del viceministerio obtuvimos un oficio dirigido a los prestadores de servicios de salud a nivel nacional que les recordaba que la prestación de servicios de salud reproductiva era parte de atender la emergencia, porque las mujeres embarazadas y los niños continúan con las necesidades de prestación de servicios de salud aún dentro de la pandemia. Lo que sucede es que ellos se hacen menos visibles y sus necesidades en salud y atención a veces no se visualizan. Nosotros entonces trabajamos Congreso, Ministerio de Salud, y lo que hacemos es traerlos a la agenda, nuevamente a la agenda política y a la agenda pública. Porque aunque el COVID consume mucho del recurso humano, del presupuesto, no debemos olvidar aquellos derechos a la salud fundamentales, como es el caso de la salud materna, neonatal e infantil.
Thank you so much, Dr. Montenegro. Before I come to you with the second question, I want to remind our attendees to click on the globe icon at the bottom of the screen and select their preferred language. I think some people are still having challenges with interpretation, so please select your preferred language. But also, just to remind us that in case you do have a question, post that in the Q&A box. We'll be able to pick it up, or even in the chat. We do have a team that is picking up those questions. Now, let me again return to you, Dr. Montenegro, just to share with us about the greatest lessons you have learned from the work that you have been doing with the government and how you are applying that in terms of supporting pregnant women, adolescents, and others to access COVID vaccinations. What have been the lessons that you have learned and how you are applying them? Yes.
Bueno, podría decirles que el mayor resultado que hemos tenido es la visibilización de las mujeres embarazadas, incluyendo las adolescentes embarazadas, que en Guatemala es un 30%, dentro del Plan Nacional de Vacunación COVID. A medida que avanzan los estudios y la evidencia científica, sabemos que a partir de abril o mayo ya se hablaba del acceso de las mujeres embarazadas hacia la vacuna del COVID en países desarrollados. En Guatemala es hasta el 27 de agosto cuando se publica el lineamiento para que las mujeres embarazadas puedan tener acceso a la vacuna. Pero en Guatemala el 30% de los embarazos se dan en mujeres adolescentes, lo que nosotras llamamos menores de edad, o sea, menores de 19 años. Fue un proceso de incidencia el traer la evidencia científica, el traer los datos de los embarazos de las adolescentes en Guatemala y que el lineamiento pudiera tener, basado en evidencia científica, las vacunas que son para las adolescentes embarazadas y las mujeres embarazadas. Aprendimos también que uno puede hacer lineamientos y pueden haber políticas públicas, pero hay que tomar en consideración los temores, las preocupaciones de esas mujeres embarazadas, porque de otra manera vamos a incrementar la oferta, pero no va a haber demanda. Durante el embarazo es un tiempo vulnerable y la mayoría de mujeres lo que les preocupa es que a su bebé le vaya a causar algún daño la vacuna. Entonces, trabajamos. En esto de la pandemia es sumamente importante el trabajo en alianzas, el trabajo multisectorial. Nosotras somos sociedad civil, hay asociaciones de infectólogos, pediatras y demás. Hicimos con el Colegio de Médicos, los infectólogos y la Asociación de Obstetras, hicimos una campaña de comunicación que ahora es apoyada con el Ministerio también. Y en esa campaña hay mensajes claves dirigidos en idiomas locales, porque igual tenemos que trabajar el tema de la oferta, sabiendo que tiene que haber abastecimiento de vacuna, tiene que haber todo el control de la cadena de frío, pero igual tenemos que trabajar con las comunidades, porque si no vamos a tener mucha oferta, pero si no incluimos a la comunidad en sus preocupaciones y en sus ideas en relación a la vacuna, vamos a tener poca demanda. Entonces, en este momento trabajamos en alianza para que la vacunación llegue a las embarazadas y también a las adolescentes embarazadas. Muchas gracias.
Thank you so much, Dr. Montenegro. Now, And thank you so much for emphasizing the issue of multi-sectoral partnerships in this work. I think sometimes we often forget that. But let me pivot to somebody who is closer to me in terms of distance compared to all the other panelists. That is Tracy. She's also from Uganda. And Tracy, I want to talk to you about how nurses in Uganda came together during the pandemic period to push for policies to support nurses, to involve nurses in pandemic response decisions, but also improve care and health system resilience. What was the experience of the nurses? Over to you, Tracy.
Thank you so much, Esther. There are about over 73,000 nurses in Uganda, and by far the largest trained health worker group in Uganda, compared with about 4,000 doctors as of 2015. Now, during this time, I must say I have been inspired by nurses and midwives' adaptivity, by writing op-eds, by advocating for PPE, for inclusion at the table. They have conducted research, and all this while continuing to serve diligently at the front line and taking risks. A great example is the Nurses and Midwives Think Tank, which is a group of nurse and midwife leaders in Uganda that came together in the face of the pandemic to advocate for the needs of the nurses and midwives in the early days of the pandemic, which was about March 2020. The think tank comprises of nurses from nurse leaders from academia, Ministry of Health, private health facilities, regional referral hospitals, major hospitals and research institutions, specialized nurses, INGOs. They self-mobilized to form a strong group of advocates, meeting every fortnight to share challenges that nurses and midwives are facing and to innovate solutions. Now, I personally formed a group with about 130 nurses to do organized advocacy. We called it the Nurses and Midwives, the Uganda Nurses and Midwives Hub, and it's still in existence right now. During that time, we wrote pieces in media, the leading newspapers in Uganda. We used the platform to gather ideas on how to solve the various issues that we're facing at that time. And then working under and together with Think Tank, we helped to design and facilitate a series of writing webinars to encourage nurses to use their voice and to push out information using social media to light fires under the people who make the decisions on health worker policies in this country. Many nurses from the hub personally tweeted the president, including myself. And a study during that time that was conducted by two really highly esteemed colleagues and nurse leaders from the think tank was assessing the nurses' perspective on COVID-19 in Uganda. It was a pilot survey, and it informed on the greatest needs of nurses and midwives, which was PPE at that time. And it also assessed how well prepared knowledge-wise and skill-wise the nurses were to handle COVID-19 outbreak. And of course, there were gaps that came through from that study, and that informed a lot of the advocacy efforts that were then undertaken by Think Tank. Think Tank also worked together with the Ministry of Health to advocate for PPE, but also did fundraising for PPE, which we handed over to the Ministry of Health to further support the government's efforts to protect nurses and midwives all over the country. And then also advocated for nurse representation on the National Task Force together with officials from the Ministry of Health. We saw purchase and provision of PPE for frontliners become a priority. And from these efforts, the Nurses Newsletter was also born. Additionally, WhatsApp groups around the country that were created at that time created a sense of belonging. They provided an environment for corporate mental health sessions where people would come and vent, provided a platform for mentors to mentor younger nurses, senior nurses to mentor younger ones. And then also, I personally met 3 great nurse leaders who are still mentoring me today from 3 different nurse and midwife WhatsApp groups. And the story is not different for many, many nurses who are now part of these large WhatsApp groups.
Thank you so much, Tracy, and just emphasizing the importance of mentoring and ensuring that nurses come together, work together to influence policy. Now, I'm going to ask you a question, and I will also ask the same question to Lillian. What can the global community do to foster inclusion of nurses and other health workers, like the community health workers, in policy dialogues and in scaling up promising practice? What can the global community do?
I must say involvement of nurses and all health workers in policy dialogue has really come out as a critical issue during this time. With COVID-19 has come the opportunity of using technology, of scaling technology across the continent and also to community health workers as well. This has opened up doors for frontline health workers, community health workers, to dialogue with decision makers. The global community can work to always ensure that there is a voice representing various groups of health workers. For example, before having a dialogue on any policy, or even thinking about any policy that affects health workers, they should think through who would represent the different healthcare worker cadres or the different constituencies best, using already established structures such as professional associations and groups to represent. And also draw out, frontline health workers who usually do not volunteer for a dialogue because they are working nonstop. And professional groups can help draw out the frontline health workers to inform these dialogues. And my second point is inclusive policies need to be followed by action. If the point is to include health workers, then they should be included. And we shouldn't just talk about including them. Inclusion also counts more at the beginning rather than the end. True inclusion means health workers are in the room at the table with a chair that is designated to them because they belong. Prioritizing, developing, informing, and not just approving a prescribed set of actions that was determined in their absence or in our absence. So inclusion needs to be more inclusive. And I can't stress that enough. It must be measurable and there should be accountability for inclusion goals. And I am highly privileged and honored to be part of 2 organizations that are really truly living out this value. Last Mile Health and Frontline Health Workers Coalition are doing a really great job of involving frontline health workers in important dialogue.
Thank you so much, Tracy. I'll come back to you to ask you specifically about your work with Last Mile Health, because I know that you're the technical advisor in Uganda. But let me pose the same question to Lillian. Lillian, what do you think the global community can do to ensure inclusion of nurses and other health workers in policy-making spaces and dialogues? What do you think?
Thank you, Esther. I think the global network needs to realize that the majority of the workforce is the nursing team. And when policies are formulated, consideration is on planning, but the other stages are left without real responsibility to anyone to take it up. So you find that policies are being created world over, and nurses have to implement what they didn't plan for. So you find that we are creating policies that cannot be implemented because the ones to implement are not there at the table. Like Tracy has said, you cannot just plan. You need to also know how you're going to implement it and who's going to be responsible. So we need to be accountable for all these policies that we are formulating overnight. Because I'll call them overnight because the thought through process is not complete. We find that most policies that are looking at health workers, they do not align to the majority. And you find that nurses are always left out, and they are key at the bedside. Because whatever you implement, it has to put the patient at the center. And that is becoming a challenge nowadays. The global community needs to realize that for us to move as a health system, we need people that will drive to the end, not people that will stop midway and say, this is not my job. That has to be corrected. Also, when we're looking at tapping the potential of Africa, we know that developed countries are overusing the resources in Africa because they know they are cheap. There are no systems in place. There are no policies that govern how health workers move from one region to the other. This has to be looked into for us to win. We will not have a situation where the developed countries are winning and Africa is lagging behind because all the experienced staff have migrated out because they are seeing the greener pastures that side. We need to create a framework that provides for developed countries capitalizing skills development as well as human resource for health in Africa to ensure sustainability in all regions. As they tap in the skilled manpower, they need to create policies that favor skills retention also on the other side, unlike a one-way system. This has proved a huge burden for us in Africa. Today, I'll plan my schedule for nurses. Tomorrow, the nurse is leaving. I can't stop that nurse. This is a dilemma to a nurse leader in Africa. I always cry in tears because I don't want to leave my motherland. I want to do the best I can in my motherland. I want to create a system that is resilient, like in the developed countries. How do I do this if all my friends have migrated? I may be the only one from my team. From my class intake, you find I'll be the only one remaining. So that shouldn't be the case. It has to be a win-win situation, both sides, developed and non-developed countries. We need to create policies that will address the future, not policies that address today only.
Thank you so much, Lillian. I know you've spoken right from your heart, and thank you both for emphasizing the issues of inclusion, representation, but also accountability. It is very important. Now, let me come back to you, Mr. Habab Alam. What do you think we should do to prepare for future pandemics? From where you sit, what do you think we should do to prepare for future pandemics?
Well, the most important learning that we have during this COVID-19 pandemic is that we didn't have any plan B. If I tell you about the Bangladesh family planning strategy or service delivery approach that government has been following for last 30 years or so, it's very straightforward. There is no alternative plan. There is no prediction that something might happen and we need to switch the gear, or we need to find alternative solutions to some of the exceptional problems. So that's the kind of arrangement we need to have, because we don't know what is coming next. There might be a different kind of pandemic, or there might be a different kind of disasters that we need to address if we want to maintain, or if we want to continue with the service delivery system. So that's the preparation I think we all should think about for future.
Mm-hmm. Thank you so much, Alam. That's powerful. That's very powerful. So let me ask the same question to Dr. Montenegro. What do you think we should do to prepare for future pandemics? Share with us your ideas.
Sí, muchas gracias. En realidad debemos aprender de lo que estamos viviendo en este momento. O sea, el tema de la política pública centrada en los beneficiarios, en el personal de salud, el tema de la equidad en la repartición de las vacunas y de los grupos vulnerables a los que se tiene que llegar. Pienso que basado en lo que ya hemos vivido, hay que preparar el futuro. Y el futuro tiene que ver con políticas públicas donde exista equidad y existan los recursos para poderlas implementar. Al final, en salud, vamos a tener un resultado en el marco de la pandemia, pero el tema de la desnutrición, de la pobreza y todo lo que conlleva la pandemia en sí para la población, son temas que tienen que abordarse también en el marco de las políticas públicas para que no retrocedamos 20 o 30 años de desarrollo. Muchas gracias.
Thank you so much, Dr. Montenegro, for always reminding us that we need to move the policies from the capital to the clinics. Definitely that's important. Policy implementation remains key. Now, let me remind our participants that please continue to post your questions in the Q&A. We'll be picking them up, and of course, our panelists will be responding to them. So we do have a question here, and this one goes to, actually to all the panelists, that we have. As a result of the pandemic, and this I will start with you, Tracy. As a result of the pandemic, how has the relationship between civil society and policy makers shifted? Has it improved? What are some of those changes that you have seen in terms of how civil society is relating with government? Over to you, Tracy.
I think in my experience, we have seen a greater collaboration and a recognition of the value that private society brings to health sector and health sector interventions. And we have seen ministries of health and governments actively involving, for example, me and my team are at Last Mile Health are part of various subcommittees on the COVID-19 response. And so there's been greater collaboration right from the design stage of implementation, right from the design stage to implementation of various interventions and activities that have been targeted to managing the pandemic, and also to targeted to ensuring the continuity of essential health services during this time. Because whereas the pandemic is still raging, mothers are still giving birth. I know one of the panelists did mention that children are still malnourished, malaria is still raging, and all communicable diseases and other chronic diseases are still in the population, and they need to be treated. So we've seen, at least in Uganda, greater collaboration, more involvement of the private sector more than ever before. Government and private sector sitting at the round table and saying this is going to work and this may not be able to work.
Thank you so much, Tracy. I'm going to ask that same question to Dr. Montenegro. How, as a result of the pandemic, how has the relationship between civil society and the government shifted? In Guatemala, is there an improvement? What is different?
Y ha tenido sus procesos. Yo diría que en una buena gobernanza hay que equilibrar sociedad civil, gobierno y las otras autoridades como el Congreso de la República. Pienso que el sistema de salud se ve presionado ante la emergencia, y presionado recursos humanos, presionado dinero, presionado vacunas. Entonces, una sociedad civil que solo señala las brechas y los errores que se está cometiendo, es una sociedad civil con quien va a ser difícil sentarse a negociar, a conversar y buscar propuestas. En nuestro caso, hemos tenido situaciones un poco de tensión cuando las embarazadas no estaban incluidas dentro del plan de vacunación, o cuando las adolescentes embarazadas no estaban incluidas dentro del plan de vacunación, porque se pensaba, si pongo adolescentes embarazadas, es como estar diciendo que estoy promoviendo que las adolescentes se embaracen para tener acceso a la vacuna. Entonces, nuestra relación ha sido propositiva, de sentarnos con datos, con evidencia, en el marco de los derechos de la población, y sentarnos con las autoridades que toman decisiones, y que estas autoridades nos nombren técnicos o técnicas, porque con los que se trabaja el tema de los protocolos y normas no es normalmente con el ministro o la ministra, sino es con su equipo técnico responsable. Pienso que hemos aprendido mucho en Guatemala. Tenemos una buena coordinación con el Ministerio de Salud, lo que sería el Seguro Social, y también guardamos la relación con los prestadores de servicio, que son los que dirigen a nivel de los departamentos. tenemos un objetivo común, que es mejorar la situación de la población y que la vacunación y los servicios lleguen a todos y todas. Y entonces en ese marco es posible discutir. Hay momentos de tensión en los que hay que como que bajar el perfil, porque no siempre se está en la mejor disposición de discutir, pero a través de tener un objetivo claro, pienso que lo hemos logrado bastante bien con el Ministerio y con el Congreso de la República. Gracias.
Thank you so much, Doctor. Let me ask the same question to Alam. Has the relationship between civil society and the policymakers shifted? Is there an improvement? What change do you see in Bangladesh? Over to you.
Well, like most of the other countries, Bangladesh health system was also not prepared to address the COVID-related challenges. At the initial stage, all of us found ourselves helpless. We were struggling to find out the alternative ways of providing services. So given that situation, as I have mentioned earlier, we facilitated a task force. Government formed a task force, taking representatives from different stakeholders, including civil society. And they had series of consultation, they had series of brainstorming sessions to find out the way out. And we have seen a lot of improvement as far as coordination with civil society is concerned, with the government policy level people. For example, I can tell you one thing. At the initial stage, when government developed a digital platform for COVID registration, there was no option for transgender population to be registered for COVID vaccination. And in consultation with the civil society, government was able to have an option for the transgender population and the disabled population as well, so that they could register and they could have special arrangement for their vaccination. So over the last 6 months or so, we have been seeing some improvement as far as coordination with civil society is concerned. Yeah, thank you.
Thank you so much. Thank you so much for sharing that experience with us. Now, my next question is to Lillian. Lillian, you spoke very passionately about the issue of health worker migration and health workforce migration. So I want you to speak to us about, there's a question that someone has asked about how the pandemic is going to dramatically increase the migration of health workers from low and middle income countries to high income countries. What are some of the concrete examples of how low and middle income countries can respond to a challenge of that nature?
Thank you, Esther. In low middle income countries, as of now, have no clear policies on how to stop these migrations. This requires a multi-sectoral approach between developed countries and the poor economies. It's a big challenge. We've had sittings, even in Zambia, where we're looking at the human resource for health as a commodity package. Because for us to win, it has to be exported and like being grabbed. The current situation is like that. Developed countries are grabbing our staff. These are the most dependable staff that we have. A nurse who's had experience of 10 years is not a nurse equivalent to a newly trained. And you find that a lot of effort, a lot of investment has gone into recreate this nurse from a basic nurse to a specialized nurse who's capable of doing multitask care as compared to the ones that are left for us to have. It's easy, yes, if a nurse leaves, you employ another, but the quality of care shall never be equal. it will take 10 years for that nurse to equal to the one who has left. So as member countries, our cry is that policies are created that will harness the available resource. We are not saying no to them migrating. What we are saying no is to how many will replace that nurse that has gone. If a person like me who's reached master's level, I leave today, I've been in service for more than 15 years. Even if you were to replace me with a basic nurse, you need 10 of them to do the tasks that I'm able to. So can the replacement ratio from the developed countries equal to the cream again? It's like we're remaining with the bottom cake and the cream is gone. So as Africa, we have to face reality. We really have to face it.
Okay, thanks. Thanks so much, Lillian, about the importance of ensuring that there are policies in place. Let me ask the same question to you, Tracy. How do you think low and middle income countries like ours, Uganda, can respond to the challenge of health worker migration? How do you think we can respond to that?
I think for me, I very much agree with what Lillian has said. But I would also like to add that I think about why do health workers leave? Why are they migrating? It's because of the poor pay. So we need to improve the remuneration for health workers. I know we have been emphasizing a lot that clapping is not enough. A standing ovation is not enough. If we really do recognize the value of nurses, especially now that we've been thrown in the spotlight during the pandemic and we are at the front line of the management of the pandemic, and if the value is being seen across civil society organizations, development partners, and governments, then it should translate to the salaries that nurses are getting. If the risks have increased for a nurse that is working in the ICU, that working in the hospital, because they're not, some of the COVID-19 patients are asymptomatic. So the risk has increased of catching a disease. If that risk has increased, is there a risk allowance for a nurse that has stayed on? So those are things we need to really, those are low-hanging fruits. Increase the salary of nurses, revise the payment scheme. That's why we're going, that's why nurses are going abroad, for better pay. And then 2, training. Lillian hinted on this, but we need to avail scholarships for nurses and midwives to upgrade. There is emphasis on upgrading, but there is willingness amongst the nurses that I've interacted with, but they do not have money because, again, the salaries are low. And by the time they get their salary at the end of the month, there's bills, there's maybe children they have to pay for. And so upgrading by oneself on a small salary may not make sense at that moment. But if there is a scholarship, then a nurse who has a certificate can then get a diploma, and a diploma nurse can then get the opportunity to get a degree, and then a degree nurse can then upgrade to a master's, and that will show in the quality of the healthcare that is being provided. It's so much higher if the training is also specialized, and then those with degrees can specialize, and then we shall see this translating to patient outcomes. We shall see translating to the quality of healthcare services delivered across health centers. So training, salaries, and then also, I also talked about, Lillian talked about policy, and I want to emphasize inclusion of nurses in policy making. This is something that has just been talked about so much, and I'm just dying to see more nurses at the policy making level making decisions, because we can, right, Lillian? We can. And so those 3 things I really wanted to add.
Thanks. Thank you so much for raising the issues of remuneration. I'm just running through the chat and I see quite a number of participants actually do agree with you, but also those that are skeptical about, the comparison in terms of remuneration in high-income countries and low-income countries, and how, low and middle-income countries can actually address that. So, but there is hope, definitely. There's hope. I want to ask that question to Dr. Montenegro to share from the experience in Guatemala. How can we get How can we address the health workers migration issue? I don't know if it's a problem in your geography at all. Please share that with us.
Bueno, en el marco de políticas para los trabajadores de la salud, pienso que es un campo que tiene que trabajarse bastante en muchos de los países, porque tenemos relativamente pocos marcos legales que le den como cierta sostenibilidad o ciertos beneficios a los trabajadores y a los trabajadores de la salud. Y más en este marco de la pandemia han surgido como nuevas necesidades. Y no hablo solo de necesidades económicas, sino hablo de necesidades de formación, hablo de necesidades de salud mental y hablo de nuevas estrategias que los coloquen en menos riesgo y que permitan una mayor cobertura de la población. Trabajadores de salud en Guatemala también son, por ejemplo, las comadronas, que son las que atienden los partos, que no son reconocidas como trabajadoras de salud porque no están dentro del sector, pero que sin duda ocupan una función muy grande en el marco de la atención y acompañamiento de las embarazadas y de los partos. En resumen, yo diría que los trabajadores y trabajadoras de salud tienen que tener una voz dentro de las políticas públicas, o sea, se necesita su representación porque ellos son quienes más conocen como las necesidades. Ahí entramos un poco al campo de la organización como sector salud, como trabajadores y trabajadoras, pero el tema de que estén representados dentro de las políticas públicas y que hayan marcos legales, me parece que son importantes también para darle frente a la pandemia. Muchas gracias.
Thank you so much. You've all been very fantastic. So I know we don't have a lot of time left, so I'm coming to the panelists for your parting shot, your last message to the attendees, to all the participants before we close this, this webinar. Let me start with you, Mr. Alam.
The message is very clear. We have a long way to go still. We don't know when the COVID pandemic would be over, even though we are expecting once the vaccination is successfully covered, situation might improve, but we are not sure. So given these uncertainties, so we all need to be very strategic, and we all need to concentrate on coordination. We all need to be united so that we could overcome this hard time, we could overcome this challenging situation. Thank you.
Thank you so much, Alam. Let me come to you, Dr. Montenegro, for your parting shot.
Y muchas gracias. Creo que el compartir y el participar, aunque pertenecemos a diferentes continentes, tenemos similares problemas en el marco de los derechos y el acceso a salud. El aprendizaje ha sido grande, tenemos que seguir trabajando, aprender a trabajar en alianzas, aprender a tener objetivos concretos y claros. No podemos resolverlo todo, pero sí tenemos que definir qué vamos resolviendo paso a paso y cómo apoyarnos en el marco de políticas públicas para darnos sostenibilidad y la participación multisectorial. Muchas gracias por la invitación.
Thank you so much, Doctor. Let me come to you, Lydian. Your parting shot, please. Lydian, are you still?
I'd like to thank you. I'd like to thank the team for organizing this wonderful session. I've learned a lot, and it's an eye-opener. We are in a global village. Whatever we do, we have to be realistic. It's a win-win situation for everyone. Health workers cannot be sustained if global efforts are not well coordinated. Thank you.
Thank you so much. And finally, Tracy, your parting shot.
Thank you so much, Esther, for moderating, and thank you to my fellow panelists from whom I've learned so much today. And thanks FHWC and partners for organizing. I just want to say that it may seem that a lot of the interventions we may have discussed today may seem to be COVID-19 focused, but I just want to stress that COVID-19 has just given us an opportunity to use the spotlight that has been placed on health workers, nurses and midwives and all cadres now to build foundations for stronger health worker involvement where it matters for future nurses and for future midwives. And what we do now in this moment is going to influence a lot the challenges or not the challenges that future health workers will face. So we have a lot to do.
Thank you. Thank you so much, Trace. Indeed, we still have a lot to do. Now, unfortunately, we are out of time. I want to express my gratitude to our speakers for sharing their time and expertise with us today. It was great to hear your perspectives, definitely. And for those who attended, thank you so much for your engagement and very thoughtful questions. I know some of the questions have not been responded to because we are out of time, but please let us keep the conversation alive via social media and other spaces. Do tag people that you know attended the meeting, some of the decision makers in your country or your region, so that we keep this conversation alive. And with that, our time is up. I want to thank you again for your attendance and your engagement, and also a great appreciation to the coalition that put this interesting conversation together. Thank you so much. Have a wonderful day.